Okay, let's dive into this clear, strict mental roadmap we're going to follow today to conquer this topic. 1. The Truelove and Witts classification. 2. Stepwise UC management. 3. A key clinical pearl. 4. The classic exam trap. And finally, 5. A quick recall question. Section 1. Truelove and Witts classification. Grading the severity. These are basically your foundational ground rules. Right. Before we can even think about treating a patient with UC, we have to establish the ground rules for grading how severe it is. It's kind of like a giant puzzle, and the Truelove and Witts classification categorizes it into mild, moderate, and severe based on 2 main pillars: stool frequency and systemic toxicity. Let's walk through the exact cutoffs here. For mild disease, we're looking at fewer than 4 stools a day. The pulse is totally normal, under 90 beats per minute. Temperature is completely normal, under 37.5 degrees Celsius. Hemoglobin is robust at over 11.5, and the ESR, that inflammatory marker, is quiet, sitting at under 20. But watch what happens as we step up to moderate disease. Stool frequency bumps up to 4 to 6 times a day. Pulse might kick up to exactly 90. Temperature can hit 37.8. Hemoglobin might drop to about 10.5, and ESR creeps up to 30. And then we hit severe. This is the red zone. Stools are 6 or more per day, and crucially, they contain blood. The pulse is racing at over 90, temperature spikes above 37.8, hemoglobin drops below 10.5, and ESR shoots past 30. Notice that incredibly clear numerical step up across every single category? So, the crucial point is this absolute rule. To officially classify disease as severe, a patient requires 6 or more bloody stools a day, plus at least 1 systemic toxicity feature from the criteria we literally just looked at. The stool count alone, not enough. It's the combination of the 2 that actually makes the diagnosis. Section 2. Stepwise UC management clinical pathways. Let's transition into how we actually treat this. And this brilliantly illustrates how mild disease treatment is entirely dictated by the anatomical extent of the inflammation. If the patient just has proctitis, meaning the inflammation is strictly confined to the rectum, we use topical 5-ASA. It goes straight to the source. If they've got left-sided disease, we still use that topical 5-ASA, but we might add oral 5-ASA just to ensure full coverage. Finally, if it's extensive disease spreading further up through the colon, we rely on oral 5-ASA as the baseline, and we can potentially add other therapies depending on how they respond. Now, when a patient presents with moderate disease, the pathway changes to a stepwise escalation. Step 1, you optimize their current 5-ASA therapy. If they have an inadequate response to that, we move to Step 2, which is bringing in corticosteroids for induction to rapidly cool down that inflammation. If that still doesn't quite get the job done, Step 3 is escalating to immunomodulators or biologic and small molecule therapies. That choice really depends on exactly how severe their symptoms are and how they've responded up to this point. But guys, when we hit severe disease, the tone completely changes. Severe disease means immediate hospital admission, no exceptions. This is an urgent, aggressive initial protocol. You must start IV fluids and correct any electrolyte imbalances immediately. You absolutely must initiate VTE prophylaxis. You hit the inflammation hard with IV corticosteroids. Simultaneously, you're running stool testing, explicitly checking for C. diff to rule out a superimposed infection. You'll also do a flexible sigmoidoscopy when appropriate to actually visualize the mucosa. And of course, you give a blood transfusion if their hemoglobin drop makes it clinically indicated. Let's move to and see how this builds if that initial hospital management just isn't working. We started with Step 1, IV corticosteroids. But if there is no adequate response to the steroids, you don't just sit around and wait. You immediately trigger Step 2, rescue therapy. This means utilizing infliximab or cyclosporin in the right patients. And if medical therapy completely fails, or if life-threatening complications develop, we have to reach Step 3, the surgical option. An urgent colectomy. Section 3. Key clinical pearl. Identifying toxicity. Listen closely, because this is the insider info. This is exactly where we separate the textbook readers from the sharp clinicians on the ward. We've mentioned that acute severe ulcerative colitis is defined as 6 or more bloody stools a day plus at least 1 systemic toxicity marker. Well, here is your quick reference list for those markers. Tachycardia, fever, anemia, raised inflammatory markers. That's it. And remember, you only need 1 of these alongside those 6 bloody stools to pull the alarm and diagnose severe disease. Do not wait for all 4 to show up before taking decisive action. Section 4. The classic exam trap. How they try to trick you. Pay close attention to this one. Now, what's really interesting about this slide is how it highlights a core tension that trips up so many students. Exam raters love setting traps here. It is completely incorrect to diagnose severe UC based on stool frequency alone. If a patient is passing, say, 10 bloody stools a day, but has completely normal vitals and blood work, they actually do not technically meet the Truelove and Witts criteria for severe disease. The correct exam passing answer requires those 6 or more bloody stools plus at least one systemic feature. You always have to look for the heart rate, the temp, or the blood results in the vignette before you lock in your answer. And here is a massive, non-negotiable clinical warning for you. In acute severe UC, you absolutely must avoid routine antidiarrheal drugs and opioids. Why? Well, because giving these medications can precipitate literally one of the most feared complications in all of gastroenterology, toxic megacolon. When the colon is severely inflamed, slowing down gut motility with opioids or antidiarrheals can cause the colon to rapidly widen, which leads to a life-threatening perforation. Never, ever choose these drugs in a severe UC vignette. Section 5. Quick recall question. Test your knowledge. Let's see what's stuck. Let's put this straight to the test. A patient presents with 8 bloody stools per day. Their pulse is 96 beats per minute, temperature is 38 degrees Celsius, and their hemoglobin is 10 grams per deciliter. Look closely at those numbers. Elevated pulse, elevated temperature, low hemoglobin, high stool count. I'll give you a second to think about it. So what is the severity? The answer is severe ulcerative colitis directly by the Truelove and Witts classification. They have more than 6 bloody stools, and they clearly have multiple systemic features, including tachycardia, fever, and anemia. Mastering this classification doesn't just earn you marks on a test. It allows you to walk onto a ward, look at a patient's chart, and instantly recognize who is deteriorating and needs immediate aggressive intervention. It literally saves lives. So next time you see a patient with bloody diarrhea, ask yourself, have I checked the systemic markers? Keep reviewing this explainer, trust the criteria, and stay focused. You've got this.